all, and a big welcome, warm welcome to one and all, and a warm welcome to Dr. Sanghamitra Madam too. Dr. Sanghamitra is the leading physician for palliative care, Assam Cancer Care Foundation, and she has obtained her master's on top of her other degrees from Cardiff University, and she's a volunteer for Ajwin Healthcare Foundation and an active member of the IAPC too. And she is also a leading trainer for the Ministry of Health, Family Welfare, India. And above all, she is a close associate to Palim India. And next, what I would like to mention is she gave the important topic of introduction to palliative care. Now she's going to talk to us on one of the significant, most important, essential topic of the whole palliative care, ethics of palliative care, which all of us have to understand properly to render palliative care service appropriately. Over to you, Madam.
Thank you, Radha ma'am, for that introduction, and thank you, Shri Priya also. I would like to straightforward go to the presentation because it's a long one, and it will be very good if I can get responses from everyone. In the middle of the presentation also, everything is welcome because ethics, when we learn, has to be example based and based on the day-to-day practice that we do. So I'm just sharing my screen. Is this available?
Yes, ma'am. Visible. We'll just need to go into the slideshow. Yes, ma'am. Perfect.
All right. So I would like to first go for the definitions and then the 4 cardinal principles of ethics, and then very important and hot topic that we always try to slip into while doing a conversation is the topic of euthanasia. So by definition, ethics are the moral code of behavior, and ethical principles are said to be a set of principles that too in a moral account, which should function as an analytical framework that expresses the general values underlying the common morality. So basically, we are inside a protective mechanism for ourselves to practice something that we get license of, and at the same time, we need to be correct in all our actions that we do towards a human being, and that's because of the fact that we are dealing with human beings and not machines. So we have to understand that ethics are by far the protective mechanisms taken by a professional, and for a medical point of view, from the point of view of palliative care, we have to justify our actions. We have to justify our treatment plans and all other interventions that we do for a patient. So ethics of palliative care are simply those of medicine in general. And having said this, we have to understand that we as doctors have a dual responsibility. One is to preserve life, and second, it's to relieve suffering. So we have to do both these duties together. And but having said this, we have to understand also that while we come towards the end of life, the relief of suffering becomes more important as preserving life becomes increasingly impossible, because we are not gods. Death is something which is inevitable, and that is the reason why we have to give an importance to relieve the suffering of people, rather than trying to go on putting our actions into preserving life. So there are 4 cardinal principles as applied in palliative care practice. They are patient autonomy, which means what does the patient want, and does the family understand the patient's preferences? That is also very important, because unless and until, in a country like India, where we have a close family, close-knit family, if the family doesn't understand what we as patients want, perhaps the action will not be justified. The autonomy of the patient will not be there. Secondly, it is beneficence. We all know, will it benefit the patient? Any of our actions, is it going to benefit the patient? And the non-maleficence, is it going to harm the patient? So we have to keep harming the patient at bay. And then last but not the least, the cardinal principle of justice. So is it a fair utilization of resources? So we'll come one by one to all these principles. So the first and the foremost that I want to ask myself and all of you is, why at all, do we have ethics around us? And why is it that we always have to think about, justifying one action? Why is it like that? We could have actually, categorized all our actions into, this is for patient autonomy, this is for beneficence, this is for maleficence, this is for justice. We could have actually properly nomenclatured everything like that. But what happens? There is always an intersection or a crossroad where we find ourselves as trying to justify 2 actions at one time, or maybe 3 actions at one time. So these things, these crossroads lead us to something called the ethical dilemma. And it is a conflict of moral principles, and they occur when a person faces certain situations where adhering to one particular principle might result in the violation of the other. So it is as simple as I have read out, and let's see how these ethical dilemmas create problems for us, and how are we going to actually overcome these ethical dilemmas. So this is an example of a patient. He has a jaw tumor, and you can see there is a orocutaneous fistula, and he is an elderly person in severe pain. There is no distant metastasis as of now, and we have actually decided to treat this patient, as the patient's cancer seems to be in a treatable condition, or so to say, convert the condition from acute to a chronic kind of a disease, if not total cure of the patient. Now, for this simple reason, we need to put an NG tube insertion so that we are able to start on with our treatment. Okay, the patient is refusing this NG tube insertion. So what should be our stand? I want to have at least 2 or 3 responses from everyone, so that we can proceed to the other slide. Can we have any response? You can put your responses in the chat box. can also speak if you want to, but just one maybe. Okay, we have one chat here. And okay, so Dr. Sheena George says counseling. Dr. Manoj says motivate and counsel. Okay. And
Apart from the
anything?
counseling, we have to take the consent
Okay.
from the family. Yeah. And if he's able to talk and understand, then we can get the consent from him for refusal.
Yes, right. And there is Dr. Agarwal who says maybe explain the advantages of risks associated with NG tube insertion. And if the patient still refuses, then we have to respect the patient's wishes. Very good. We should encourage him. Okay. Counsel the patient for the goal behind the procedure and explain how it will feel. Reassure to take possible measures to avoid discomfort and take counsel. Very good. I think we, in a nutshell, we do have, what we should be doing. So this actually brings us to an ethical dilemma between doing good beneficence and the choice of the patient or the patient autonomy. So as your responses are very clear, and as we can actually now think about how to, overcome this particular dilemma, because we want to do good to this patient, and we also have to give respect to the choice of the patient. So how do we do it? How do we proceed? So see, first of all, we need to understand what is actually involved in patient autonomy. What is patient autonomy? So the first and the foremost thing is that it is the right to have dignity, privacy, and confidentiality. So these three things are extremely important for the patient. Secondly, we have to respect the fact that the patient has every right to have the correct information. And then the patient also has every right to make or take his or her own decisions. And at the same time, the treatment decisions has to come as an informed choice of the patient, as correctly said by the doctor right now. So we have to take an informed refusal if the patient is refusing. But before taking the refusal, we need to check the understanding of the patient. Does the patient understands why we are going to give him a NG tube? Have we discussed the the path of treatment for this patient? Have we actually told him that after an NG tube we are going to look at the possibilities of operating or give him chemotherapy or radiotherapy or whatever, So have we actually discussed this? And has the patient understood, why we are going to take this treatment? And at the same time, why is it important for us to give an NG tube at the first step, as the first step? Okay. And then you have found out that, okay, he understands a bit about it, but then he still, he thinks that, no, it's not for me. I will not be able to, take the NG tube. Then you start exploring the reasons. Why is he refusing? Is he thinking about, okay, if after NG tube insertion, they're going to cut off my jaw, and then I'm going to be on the NG tube for the rest of my life. That is not acceptable to me. That might be one reason. He might also be thinking, oh my God, where from will I get so much of money to bear with the surgery? It's better that I just refuse to take an NG tube and be whatever I am now. So we need to explore these reasons, right? Thirdly, and importantly, as correctly said by you, it is counseling the patient. We have checked the understanding. We have also tried exploring the reasons to the best of our capability. And then we need to counsel the patient. We need to tell him that, okay, your financial problems, if there are any, we can actually get you connected to this NGO or, somebody who can help you with the finances to go through the treatment. Okay, you'll get better because the stage is not like this. You do not have distant metastasis. So all these things will actually come into counseling. And when we talk about counseling in palliative care, it is not only, giving the patient, the right information, but also trying to show him the right paths about how to go about it. We also have to tell the patient that, taking a futile decision, the difference between taking a futile decision and taking the correct decision at the right point of time. Okay, so counsel the patient. And then after all these things, the patient still refuses. He understands everything. You found out the reasons, you've tried to help him, you've counseled him, yet the patient says, no, it is my decision. I do not want to proceed further. So it is our duty to support the patient, even when the patient's decision, we do not agree with the decision of the patient. It is so happened with, in my career also, I've seen patients, they refuse to do certain things. And then, at one point of time, it really gives me a lot of disturbance, because I know that, oh my God, he's actually going towards something which he should not be going. We could have avoided that. But that, at one point of time, I used to feel annoyed at all these things. But now it's important that we give time to the patient to accept the reality. And when we say accept the reality, accept the fact that he should undergo the treatment, and it is not going to be futile. It is going to be, beneficial for him or her. And then the patient generally comes back, to me and tells me that, doctor, I think you were right in your decision, and I would like to now go for this treatment. So, these are the checklists. These are the checklist of getting an informed refusal. And when you get an informed refusal, you must not be annoyed with the patient for refusing. You must not have this tendency of telling him later on, I had told you earlier, you had not listened to me. That is the reason why you've got this. No, you have to change this attitude. Many of us do this. At one point of time, I was, I would actually do this to my patients also, without understanding things that, how that blame would actually make the patient feel so guilty about it. So it's very important that we refrain ourselves from doing that and try to support the patient at every point of his decision making, because it is us who have actually empowered the patient to apply the cardinal principle of patient autonomy. So let us come to a second case. This is a 20-year-old boy with osteosarcoma of the lower end of the femur. He now has a large tumor with multiple lung metastases and severe anemia. But he wants an amputation now. You know that the procedure is too risky considering his general condition. You try to explain the risks to him, but then he's adamant that he wants to continue with the amputation. So your responses on this. If you could just tell me what is the ethical dilemma that we are in this situation. Okay.
He already has got metastasis. So how much would it help once we ampute him? Because meds, anyways, the prognosis is bad. So he may be thinking that after amputing, he'll be all right. But then that is not the case here because he has meds. So the prognosis is going to be bad. So we should, in fact, take the relatives also in the team and explain them so that they can also try to convince him what is not good for him. He should not go ahead with that.
Right, madam. Absolutely. I completely agree with you. Okay. So we have certain responses, and it's beneficence versus autonomy, beneficence versus autonomy. So I get one response of non-maleficence. Okay. There's something outcome from the surgery from Dr. Patruni. Okay. All right. So this is a dilemma between beneficence and non-maleficence. So we want to do good by not amputating, and we want to save the patient till the day he is there. Okay. As madam rightly told us, he has lung metastasis already, and we know that the prognosis will not be good even if we amputate. And when we amputate, we know there will be a lot of blood loss, and he's already in a poor general condition. He's already anemic. So we do not want to push the patient to that. So it is a dilemma between doing good and avoiding harm. We want to avoid the harm also, and that is non-maleficence. Okay. So the first questions that comes to our mind, what are his chances of cure? Are we looking at curing the patient here at this stage of his life where the disease per se has gone into stage 4 disease? Are we going to put him through all kinds of curative therapy, if I may say so, having the proof and understanding of the facts that there are no chances of cure. So have we discussed this with the patient? We have not. We need to perhaps see the chances of cure and discuss this. Now, when we say cure, if the patient says, no, I will be cured. I will be cured. I know if you amputate my foot, then, or if you amputate my thigh, then definitely I'm going to be cured. So now the question is, are we going to give him this, amount of survival that he needs to have at that point of time? Do we have this much of, knowledge or this much of courage to actually tell him that he might pass on the operating table? So this is also an important question. Will the amputation improve his condition? So these questions are helping us out in getting, overcoming this particular dilemma for this particular patient. So we need to justify how we, tell this, or how are we going to convert our thoughts, or, give this particular bad news to the patient that going through the amputation may culminate in death. Going through the amputation may, give him zero survival. Going through the amputation may not ever improve his condition. Rather, it is going to, give him a more deteriorated condition, quality of life. So this is another dilemma. This is a 20-year-old boy with advanced cancer, and he's under your care. So the relatives have insisted that issues of diagnosis and prognosis should not be discussed with him. Now, you go for a round and you see him that he's alone that day. Now, being all alone, he asks you, what is wrong with me? Now, what will you tell him? Any responses? It is
Yeah, ma'am.
important.
Yeah, I will not reveal it to the patient directly in the first go, but I'll tell him that there is some problem with him and that we are investigating him. And as and when we will give him an idea later on. He is under investigations and we are trying to diagnose him. I will not reveal him immediately because it will be a shock to him and he is still young. He may not take it rightly. So I may not reveal in the first setting itself. When the relatives are there, maybe I can take them. I'll first talk to the relatives, convince them, and if they also agree, then we can all sit down together and then discuss with the patient in case, but not immediately. I would not reveal. Yeah.
Okay.
I think it's
yes.
important that
Yes.
the patient knows about his condition. So there's a way to deliver bad news. So it's like you first have a setting and we find out how much the patient knows about his condition. Then we try to inspect whether the patient is really willing to know about his condition. I mean, we continuously ask him, do you want to know further, things like that. Then if he still wants to know, then we have to tell him, irrespective of families, whatever they wish, because patient, we have to keep them informed about their condition. He's an adult, so I think it's important that he knows. So I think he follows spikes to deliver any kind of bad news.
Yes, absolutely right. I mean, actually, I agree with both of you in this because it will actually come by practice, madam. Why I'm saying this? Because the situation may be different for each one of us. How we deal with it, what are the surroundings that we are in at that point of time. But having said this, the baseline that we should all agree is that this boy was searching for a seclusion, was searching for a time alone with you so that he can ask you. This is the single most indicator that he wants to know. Otherwise he wouldn't have asked you this even when he was alone. You have to take this as a positive point. And then, as you rightly mentioned, we need to see the situation. We need to find out how much he knows and how much he wants to know, and slowly try to communicate the bad news, right? But I would agree to everybody who said that we have to tell this patient rightly about the diagnosis. It's like, if we try to tell him that, okay, we are doing an investigation and, we are actually going to see more reports. This is actually trying to linger him with more of his anxiety. He's already in an anxiety. Nobody is actually sharing what he's rightfully wants to know. That nobody's sharing anything with him, so he must. Yes, Dr. Surabhi has raised her hand. Yes, Dr.
Ma'am, we should communicate with the patient firstly and try to know about what the worry he has and what he want to know, and then we slowly we can counsel, and in the fourth and fifth sitting we can tell that, "Okay, you are going through this and you have to do. If you want to leave your complete your bucket list, you can do your bucket list completely. If you want to study, or if you want to go anywhere, you can go."
Absolutely true. That's what I was also trying to say. Actually, we will need to understand the fact. We have to accept, it is our duty as doctors to understand that, a person, whether he's a 5-year-old kid or a 20-year-old boy or a 70-year-old person, has all the rights to know about the diagnosis and prognosis of a disease. Okay, that is number one. Number two it is important that we also understand that the relatives, whether they are parents or, whether they are grandparents or brothers or sisters of the patient, they are trying to protect this child who is actually a child for them. For us, this is a person. A 20-year-old boy is a person, okay, is a patient. We are not going to treat him as a kid or whoever. Even if he is a kid, if the kid also wants to know, it is our moral duty, responsibility to tell the person the right diagnosis and prognosis. But then the relatives will always be in a position where they will tell us, please don't tell this to them, to our patient, because he's not in that position to take it. It's not like that. They are trying to protect their son or their daughter or their own kid from getting this bad diagnosis or this bad news. But having said this, the relatives are actually trying to protect, and we are giving this diagnosis so that the patient is able to accept, or the patient hears what he wants to hear and then go ahead and plan. As of now, he is nowhere. He's in a space where he doesn't see anything. Everything is blurred for him. Nobody has, in fact, told him that, don't worry, you'll be okay. Nobody has told that also. Everybody is okay, your treatment is going on. We are going to do this investigation. For how long? And why do we need to, stretch this band all the while? It's not justified. We should not be doing that. So it's very important that when he is alone and he initiates the question, it is our moral responsibility to give him the diagnosis and prognosis, but of course, with the suggested spikes protocol that you all may have till now learned in your communication skills.
Yeah. Can I speak, ma'am, for a minute?
Yes, please.
Yeah, actually, we have faced the situation very often. Relatives, of course, do not expect us to reveal such bad news when no one is around. When we talk to the patient alone and we reveal this bad news when the patient is alone, all by himself or herself, then that relatives really become so much agitated. Then we really fear, it's difficult for us to handle the situation. What I was trying to say was, in the first visit, when the patient asks us, I may tell him that we are doing the investigations. Then I'll go and talk to the relatives. I can take the relatives along and then reveal the news in front of the relatives, so that if by chance he does not take it properly, the relatives are there to look after and take care of him once we reveal the news.
No, Doctor, I would not actually agree with you in this point, because I'm right now not bothered about what the relatives are going to do. Okay.
Because then many times they complain also that we have revealed the news
okay.
and we make an issue out of it.
No. You have to handle the relatives also.
Okay.
That is
we
very
can reveal the news. We can reveal it to the patient directly if the patient asks.
Yes,
ethically.
That's absolutely that. This is an ethical point of thing, and for that reason, first and the foremost, you have to talk. See, the patient has asked you about the diagnosis, not after the relatives have stopped you. Okay, so I'm sure. At the point of diagnosis, the patient's relatives must have told you कि मैडम मत बताइएगा इसको.
Right. Yeah.
बिल्कुल मत बताना. हम लोग हैं, हम देख लेंगे क्या करना है. Right? Many times you have to face very rude kind of behavior from them.
Yes.
Blunt and rude behavior.
Correct.
Right? कि आप मत बताइए, ये हमारा काम है, हम करेंगे. Okay. So now at that point of time. Okay, at the first instance, you say, ठीक है, हम नहीं बताएंगे. Next, next episode, when it occurs, you actually tell the patient, "ठीक है,
Yes, that's true.
हाँ, ठीक है,
Yeah. Yeah.
कोई बात नहीं, we are going to do some more investigations. All right."
Huh.
And then you have, at that point, you have to communicate this particular thing right onto the face of the relatives. You have to tell
Yeah.
them, कि
Yeah,
अभी
yeah, we
आपका
do
बच्चा-
that.
हाँ,
Yes.
अभी आपका
Yes.
बच्चा फिर से मेरे को पूछ रहा है, मुझे क्या करना
That is what. Yeah, yeah, that's
क्या
what we
करना
do. Yeah,
हाँ?
correct. Exactly.
And
ma'am.
then
Yeah.
when the relatives say कि नहीं नहीं अब हम कर लेंगे, then you have to show them what lies ahead if you do not reveal the diagnosis.
Yeah, next time. Yeah, first immediately I do not say, but then I talk to the relatives and then I do reveal it to the patient, taking the relatives together.
No,
and
no,
we
not,
have to, of course,
not,
reveal.
no, I'm not saying that.
Okay.
I'm saying you have to reveal everything to the
Yes.
patient's relatives.
Yes.
कि अभी अगर आपने इसको नहीं बताया
हाँ.
तो आगे क्या होगा?
Yeah, yeah, we do that, ma'am.
What
Yes,
are the
definitely.
adverse effects of not giving the diagnosis to the
To
patient?
the patient. Yes, yes, we do that. That's what I'm saying. In the second round, I do that, not immediately in the first round. Maybe next day I do it, not first day itself.
Okay.
Yeah.
So
Yeah.
what I was talking about in this particular scenario, their relatives have already insisted you not to do that.
No,
Okay.
no, we do talk to the relatives and we reveal it. Of course, we have to reveal to the patient.
You have to reveal it.
Yes, yes,
This is
yes,
the
ma'am.
right of the patient. You have
Yes.
to give that
Correct.
benefit to the patient,
Yeah.
and you are actually helping the patient in that
True.
manner.
True, yes, ma'am. Yeah.
You know, at one point of time, the relatives will realize that
Yeah.
the whole episode that has happened for good.
Correct. True.
And having said all these things, you know, I would encourage you to practice this as often as possible and not, run away from the situation. Many of us do that, you know. I used to do that very often. I used to get very scared because, oh my God, 4-5 log ek saath aa gaye hain and everybody is going to kill me, like, you know. And कि आपने क्यों बताया? Why the hell did you do that? Who's going to look after him? Hi, ये हो रहा है, वो हो रहा है. They would cry and the whole situation would be like a kind of an explosion. Okay.
Right.
But
right.
that, you know, we must be trained to handle that situation also.
True. True.
If we
True.
cannot
Yes.
do that, if we cannot handle that situation, then perhaps it is better not to step inside also.
True. True. Completely agree, ma'am. Yeah.
Yeah. So
Yes.
maybe if you do think that I will not be able to handle that situation, I would advise you to take help of some professional who deals with this kind of a situation.
Right. Correct.
Like your psychologist or your counselor who's there, one of your colleagues who has been actually doing bad news and working more in palliative care situations. You would actually take help from them.
Sure. Thank you so much. Yeah.
So the question here, as I was talking, we cannot actually deliberately mislead the person, mislead the patient for that reason by withholding information and at the point where the patient is actually asking for that information. And, we have to understand that relatives are an important part of the patient's life and our lives also. But we need to put the patient on priority. Okay. So this is another scenario where we have a 50-year-old lady with carcinoma of the stomach has come to the hospital in a terminal state, probably due to internal bleeding. Her systolic BP is now 50 millimeter of mercury. She is extremely restless. Now, the question here is, will you give parenteral midazolam, which may hasten death? And this is a kind of a dilemma that palliative care specialists generally, they face a lot in their scenarios. Any answer to this question? Is this related to palliative sedation? Not really. not really related to palliative sedation. Sorry.
Stabilize her with the blood pressure to increase.
Okay.
Check all the vitals and first we have to stabilize the patient. Then think of other things and try to stop the internal bleeding where the BP can be shooted up. Internal bleeding maybe could not be arrested due to the terminal end stage carcinoma. So
Okay.
it might be very difficult. We can't even open and do the cauterization.
Right. Okay. Anything else? So, yes, concept of double effect. Yes. Risk versus benefit. Does the patient desire comfort? Okay. Okay. All right. So now it is actually related to end of life. Okay. End of life. And I think I've put this question quite, quite in advance to your end of life class. That's why, you might be having this problem. So the dilemma here is, injection midazolam is used for terminal sedation. Absolutely right. Secondly, midazolam is the gold standard of treatment of terminal restlessness. Okay. So there are two things here. Firstly, we have to prognosticate the patient. Okay. Prognostication is an important part of specialist palliative care. And when we get terminally ill patients who are slowly slipping on to end of life care or the end of life phase, so to say, we need to prognosticate firstly whether the person is actually going towards end of life. Secondly, are the symptoms reversible at this point of time? And when we talk about end of life, as you will learn and understand in your classes of end of life care, terminal breathlessness, terminal restlessness, terminal hemorrhage, everything that is related to end of life are generally not reversible. And henceforth, we will prioritize the relief of that patient at that point of time. And here we are giving midazolam to relieve the restlessness of this patient. Okay. So the question here, when we talk about dilemma, ethical dilemma, the question is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? Okay. So we have to justify why we are giving midazolam to this patient. When we know that midazolam is the gold standard of treatment for terminal restlessness, why are we not going to give that to this patient? Okay. Or why are we going to give this medication to this patient? Right. So the justification here is we have to relieve the patient of the terminal restlessness. And hence, we have to give that patient midazolam. Otherwise, the patient is going to pass away on with restlessness only. And that is the most dreadful condition for anybody to handle. Okay. And you may have seen, terminal end of life patients with severe restlessness being admitted to the ICU, strained with, all four limbs tied together. The person is, that's a very dreadful condition. Nobody should go through that particular condition, That is why we have to prognosticate. We need to understand prognostication. We need to justify what we are going to do. We need to justify why we are not sending the patient to the ICU, why we are withdrawing certain medications from the patient, why we are applying certain medication to the patient. Okay, so as I think doctor has already told us about the principle of double effect. So it is a single act having two possible four same effects, one good, one harmful, and is not always morally prohibited if the harmful effect is not intended. So our intention is to relieve the suffering of this patient, and the suffering is terminal restlessness. And that is why we are giving midazolam. Let me give you another small example. Use of oral morphine. Okay, it's a very simple example. We have been using, everybody uses oral morphine nowadays, for pain, as palliative physicians, as oncologists, as anesthetists also, to relieve pain. Now, morphine has, side effects also, very bad side effects. One is nausea and vomiting. Another one is constipation. Okay, but knowing these side effects also, we are helping the patient to get relief from the pain, and we are not actually trying to avoid use of oral morphine only to avoid the side effects. We are relieving the patient of something which is troubling even more. So that is how the principle of double effect will actually apply when we use certain other medications or we take other actions thereof. Okay, so always remember the principle of double effect, the art of prognostication, and the justification of withdrawing or withholding an action at the end of life. And I'm sure these scenarios will become even more clearer when you actually talk about or learn about end of life care in this particular course. So this brings us to another scenario, and this is a 74-year-old gentleman with advanced carcinoma of lung. He has completed a course of radiotherapy and 2 courses of chemotherapy. He's brought to the casualty. He's drowsy, his pulse is feeble, his systolic blood pressure is 60 millimeter of mercury, his breathing pattern is altered. The family now, wanted everything possible to be done for this patient. Okay. And what do we do in such a situation? Hello? Yeah. So what do we do in such a situation? Do we resuscitate and shift him to the ICU?
No.
Do we further investigate the patient? Do
No.
we see about hemodynamic and ventilatory support? Do we do hydration and nutrition? So
We need
yes.
we need to explain the actually patient's relative regarding the condition of the patient and tell them that it's not going to make much of this one.
Right. Absolutely. So in a nutshell, we need to see what is appropriate for this gentleman, right? Am I able to connect with what you are thinking? It's kind of a appropriate treatment for this particular gentleman. Okay. So this appropriate treatment could be a treatment that does not provide net benefit to the patient, may ethically and legally be withdrawn, and the goal of medicine should shift to palliation of symptoms. Is it right? Because this patient has an advanced carcinoma of the lung. He has already completed radiotherapy. He's already completed chemo. Now he's drowsy. Perhaps, we have prognosticated that the patient is now actually going towards end of life and perhaps is going to, die in some possible, maybe another 78 hours, So there's no point actually resuscitating him and sending him to the ICU, straining him, ventilating him. All these things would actually go in vain. So we need to find out the appropriate treatment for such patients. And when we talk about appropriate treatment, the key points has to be the patient's biological prospects or parameters, the therapeutic aim and benefits of each of such treatments, the adverse effects of each treatment that we do, and the need of not prescribing a lingering death. If we send this patient to the ICU, ventilate him, make him go through another 78 to perhaps 100 hours of, putting him through the ventilator, he's not even able to understand what is going on with his body, is not even able to respond. The family is always outside the ICU waiting for the gentleman to come out. Oh my God. So what are we actually doing? We are prescribing a lingering death, and we do not want to do that. So we need to understand the appropriate treatment for our patients too. Okay. This brings us to something which is called the principle of justice, and that is balancing the needs of the individual with that of the society. In a country like India, where we have so many people, such huge load of patients, the current scenario is like going to boom up to almost 300% in the next 10 years. We have to justify how we use our resources. This is a 86-year-old journalist. He has lung cancer spread to his spine, ribs, sacrum. He has a son who is a psychiatric patient. He has 6 grandchildren. There are certain goals for this family. They have 3 grandsons waiting for their Janeru Sanskar. There are limited family finances. The patient is going through such a lot of pain. Slowly, the cancer is spreading, and this patient is having increase in breathlessness. So now, are we going to admit him to this to the ICU? And is this going to be a fair utilization of our resources, of the family's resources, a location of the hospital resources, and of the society's or nation's resources? So we have to find out and justify why. It's very easy to say that we are actually going to take this patient. We have such a lot of money, and we are going to take him to the hospital, and we are going to put this patient inside the ICU. We are going to do everything that is possible in our hands. Okay, but are we justifying our work? Are we doing that? I think no. So the principle of justice is definitely one important principle that we all need to follow, because we are working in a resource poor setup when we are working in India. This brings us to something called euthanasia. And this is an act or procedure in which someone takes an inactive means, such as a lethal injection, to bring about someone's death. Okay. At the same time, allowing natural deaths or withholding or withdrawing a futile treatment is not called euthanasia. We need to understand and take home this message today, that allowing natural deaths or withholding or withdrawing a futile treatment is not termed as euthanasia. Okay. And we all know it is legal in Netherlands, Belgium, and Luxembourg. and that has been legalized since the year 2014. So there is a legal provision in IPC section 88, which says that nothing which is not intended to cause death is an offense by reason of any harm which it may cause, or be intended by the doer to cause, or be known by the doer to be likely to cause to any person for whose benefit it is done in good faith, and who has given a consent, whether express or implied, to suffer that harm or to take the risk of that harm. Now, this particular provision is present in IPC section 88. Unfortunately, we have never been able to, transform it into clinical settings. That is where everything becomes a kind of a cloghead, and we are unable to proceed further, and we do not know how to apply this particular provision when we are working clinically on our sites, and we deal with patients who may, fall in this kind of a category. And people, actually come with request of euthanizing their patients. There are many instances where doctors actually face, when I have faced at least 4 or 5 instances where, the relatives have asked me, doctor, when are you going to give the final injection? So, all these things are important for us, because we have to save our skin also. We have to be ethically right also, and we have to justify our actions also. So now there's something called futile care, and when we understand the importance of futile care, where we are actually inviting futility into our process of care, we will understand that the thin line where we have to stop. Okay, so the AMA Code of Medical Ethics have actually properly underlined that physicians are not ethically obligated to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. So remember this code of conduct, this code of medical ethics, and you will understand where to stop when you are slipping into that slope of, giving futile care to your patients. So now, why do doctors even go for futile treatment? What are the reasons? They're not oriented to, they are always oriented to curative treatment. We have to cure. I have become a doctor to see my patient walk out of the hospital smiling. Okay. Sometimes my gynec friends, they tell me, oh, Dr. Sanghamitra, you must be so depressed, none of your patients actually go out of the hospital. And on the contrary, we get to eat sweets from our patients, because we give life to a newborn, and they go happily smiling out of the hospital. So, it's really depressing when you talk like that. But then, cure or success should not be rated on the lines of what you deliver to your patients. The importance of relieving suffering is same as, bringing a smile to your patient whenever the patient is actually depressed, whether the patient is dying or the patient is in a non-dying state. Okay, so there are no training in palliative care for doctors. I came into palliative care only 15 years back, and when I had already completed so many trainings in other areas of my work. So I came to know about palliative care very late. fear of being blamed for suboptimal treatment, oh, so you're not going to give this drug to my patient. Okay, so you may not know, you don't know actually what to give, so it becomes a kind of a suboptimal treatment for people, that start blaming the doctor. The ignorance about the guidelines for end of life. There are many few doctors in India who know that there are certain guidelines enumerated for end of life. Okay. And always the question of euthanasia. Are we actually performing euthanasia by not doing that? So if you want to look for these guidelines, the end of life care policy, this is a joint position statement of the Indian Society of Critical Care Medicine and Indian Association of Palliative Care. Please go through this paper and find huge amount of proper information enumerated for all of us, and it'll be really benefited. There's a difference between killing and letting die. Okay, so if there is a moral distinction between killing and letting die, so in what circumstances is it morally justifiable for not to offer life-prolonging and life-sustaining treatment? We need to understand this particular distinction. And as I said, it cannot be a euthanasia is never a passive or an active action. Euthanasia is always active. You are actually killing the patient, by doing something with an intention of making the patient die. But if you are actually withdrawing something from the patient, it is not actually killing the patient. So using morphine and other drugs to relieve pain, is this euthanasia? No, it's not. Stopping treatment when the burden outweighs benefits, is that euthanasia? It is not. Allowing the nature to take its course, is that euthanasia? It is not euthanasia. So please go through other papers also, because I have given you a very narrow or very small kind of a concept today. You should go more, learn about it more. There are a lot of papers that have been published from India itself. Please go through that and you'll find more information on euthanasia. Also read about this particular book, Being Mortal, by Atul Gawande. And this is going to give you a very good, overview of how an oncologist, oncosurgeon actually sees death and the system of dying. So we do not want to die in the ICU. We cannot afford to die in the ICU because of so many reasons. There's health costs, there's so many other things. I will not go into details because I know we are running out of time now. But the take-home message today, we should be applying ethical principles against the background of respect for life and the acceptance of the ultimate inevitability of death. So I would like to stop my presentation here today. I might have missed quite important, few important things. And I would always encourage you to go back, search the literature, and then, see for yourself where we stand today. What are the things that we need to know about medical ethics and scenarios that surround palliative care physicians as such. Thank you so much.
A big thank you, madam. You have really covered. See, as you said, it's a vast topic, but you have to fine detail to all the important points. And I am over the moon. Being Mortal is a book which I recommend everyone to read. And one of the questions in the chat box is there, they've asked, as doctors, always we are taught to treat, but not educated enough to know when to know to stop or without. Exactly in that book, first few pages of the book, Dr. Atul Gawande, I've had the opportunity to meet him also. So it is an excellent book to be read by everyone. All of us have elders at home. So it will give you an overview, and exactly this question raised in the chat, it will teach, like in the first 50 pages or so, you will read about what, like how we are all taught about cure and thing. We are not taught about death and facing death and everything. So as students in the medical school, what happens, he would have explained everything so well. And then going in detail to the various availabilities and various different cultural aspects of caring for the elderly. It's a very nice book to read. That is one part. And then every point of today's, the 4 cardinal points are something we have to, first thing, see, when you hear about it, it's something like putting a seed into your minds, so that all of you read a bit more. So when you see each patient, either you will consider all the 4 points, whether it is autonomy, whether it is beneficence, or whether it is non-maleficence, or using of resources. So these 4 points are very, very important, and you will deal one of them, or you may deal all 4. You will have to deal all 4 of them. So you will have to take it as and when required and deal with it appropriately. There is justification for everything. So you have to know what you're doing and do good, but not harm. That is the take home. So the 4 cardinal points are very, very important. And that would be the take home message. And trying to read the book also, madam, is an excellent choice, what you have said. Like even like a couple of weeks ago, I told someone and they said, oh, that is such a good book. I've enjoyed reading it. Full of knowledge and information, said in a very nice way. So you will like, it's a book which could be read in like a couple of days. Shall we go ahead with the case presentation? And because most of the questions, madam has answered them as and when also. And last 3, what is there? I will have a look. Yes, I think everyone is appreciating and thanking madam for a lovely presentation. Okay.
Good afternoon, everyone. I'm Dr. Sheena George. I also would like to recommend the book Being Mortal. It's a very beautiful book. There's another book which all of us as medical professionals should read from Atul Gawande is Checklist Manifesto. That's also a very good book. So now I'll be coming into my presentation. Next. This is a patient, 75-year-old male patient. He's diagnosed with stage 4 carcinoma lung with brain metastasis. He was a chronic smoker since young. He was non-alcoholic. He's from a lower middle class family. He is having progressively increasing productive cough for 3 months. He has started having weakness of the limbs and doing normal work for the past 1 month, and he is having headache for 1 month. He has a loss of appetite and loss of weight, and he was diagnosed as a stage 4 carcinoma lung by doing a CT scan in a private hospital. You can skip this slide. Yeah, and the CT brain was done. It had multiple metastatic focus. Next stage. His psychosocially, he's very weak and is unable to eat solid foods. He is having deteriorating health and not able to stand or walk, even go to the toilet. He does not have pain and he is relatively comfortable on bed. He has a caring family and children, and they're taking care of his needs. He is on symptomatic, make skip this slide. It's nothing. Yeah, main concern was hearing about this case, patient was first, when he had these problems, he went to a private hospital nearby. Immediately they did a CT scan of the lung, without going into too many other investigations. They didn't even do X-ray. They just straight away went to did a CT scan, so which was very fast diagnosis. Then he was referred to a tertiary center where he had to undergo multiple tests. Then the patient went to the tertiary care hospital, where he took almost 6 weeks to 8 weeks to confirm the diagnosis. The waiting period was long, and while he was undergoing expert consultation and diagnostic test, during this time the patient became very sick. The patient was again asked to do a CT scan, and they also did a CT scan guided biopsy. In fact, the patient was told to do CT scan, and patient came to me. I said, why CT scan again? Then they showed me the slip, and it is written CT guided biopsy. So they underwent CT biopsy, and patient developed pneumothorax, and then there was a chest tube was introduced, and subsequently he was admitted to hospital for a week. Then the doctors advised him radiation, probably palliative radiation, but the relatives felt he will not be able to tolerate the radiotherapy because of his poor health status. He is discharged at home, and now at home taking fluid, diet and symptomatic medicines. This patient is free of pain, and therefore he is relatively comfortable. Unfortunately, just 3 days back, the patient passed away. So next, can go to the next slide, please. So just wanted to discuss if there is any, what are the ethical principles applied in this case, and is there ethical dilemmas, and how we can manage such cases. So this is from a purely clinical point of view I have presented, because I don't have any kind of palliative care connection. So this is purely from a clinical perspective, what are the things we can do or we should not do in such cases. Thank you.
As always, like either you can type in the chat box or unmute and ask.
Ma'am, is it possible to go to the summary slide? Thank you. Thank you. I think home-based care, I think, is a good choice for this patient. I think most patients want to, if it's been discussed with the patient, most patients would want to, pass away in their home. So since nothing could be done and he's been discharged, I think that was the best that could be done. This is something that I want to say. And maybe he was prescribed for chronic cough, he was prescribed some medications. So probably, I think it was mentioned that he's not having pain currently. So he's comfortable. So that's a good thing.
One point, as you mentioned, there have been many studies which have shown and clearly said that many people would prefer to die at home. So that has been proven by multiple studies and data collection that is what many would prefer to. So that is something what you mentioned is significant. So I just thought it's worth reiterating that. And Dr. Sheena, the second book, what you mentioned, because someone had asked in the chat to type the books, I have typed about being mortal.
Checklist
The other one, if you
manifesto. Checklist manifesto.
checklist.
Yeah.
Yes, because he was he was a leader, or he was someone who was doing about safe surgery. I think
Yes,
checklist,
yes,
WHO
yes.
checklist was,
Yes. Yeah.
so
he was-
checklist manifesto.
Yes.
Yes, because I've attended, like I got the opportunity to meet him in 2016,
Okay.
because he was the lead torchbearer for safe surgery practice.
Yes, by WHO. Yeah.
Yes. So in that time, pulse oximeters were distributed for many places and things like that. So that is when I have, so in that one of the conferences I had met him.
Yeah.
So that's what, in that he told about the second book, because the first book was a Booker Prize winner in 2014, I think.
Yeah, I think that was some other name, better something. Better.
Yeah, that's all. That was that.
Yeah,
So
yeah.
basically, this Being Mortal and these two have
Yeah.
been popular, because they are very useful book. It is because anyone needs to read. Not only so, I
Yeah.
have recommended to many people in my family, and everyone has enjoyed reading
Yes.
it, so that they are able to do very good care for their own family members.
Yes,
So
exactly.
understanding
Yeah,
is
exactly.
it's an eye opener. It's an awareness book type of thing, I would say.
Yeah.
That is regarding the book, because that was in the chat. And then like what are, see, ethical and dilemmas in this case, Sanghamitra madam, anything specifically madam would like to say?
Yeah, I would like to go to the summary slide once again, if you don't mind. Okay. And yeah, there was one more slide which was very informative, I think.
The previous one.
Yes, yes. So, so my question here is, there are certain things that we are missing out, because it says there was a gap of almost 2 months between initial diagnosis and final treatment decision. The waiting period was long while undergoing expert consultation and diagnostic tests at tertiary center. During this time, the patient became more sick and weaker. So now my question for this particular observation, did it come from the patient, or has this come from the clinician?
No, ma'am, it's come from the clinician.
Okay.
Because because if they go and meet one Monday, they'll say come next Monday or next Wednesday. So that routine, because the hospitals are very busy and they have particular days for the particular unit. So that was taking a long time for him.
Okay. And has this point been discussed with the patient or the family also?
Which one, ma'am?
This point of the gap has been
the
discussed.
patient and the patient's relative knew that there's a gap, but then they say they say come next week for consultation, then another 10 days to get appointment for CT guided biopsy. So
Yeah.
it's like that. So there was some gaps in the initial first 2 weeks, not from the tertiary center, from the private to the tertiary center. Patient themselves were debating, because in the private itself they were said that patient is quite advanced stage, so they were debating, and probably they consulted many people, then go show it to this higher place. So it is a general opinion from the relatives and other people. They went to the tertiary center, but there was a delay of around 5 to 6 weeks.
Okay. So as long as this particular point is not disturbing the patient or the the family, as kind of this is the reason why my patient today is in such a situation. So if that is
No.
not disturbing them, then
No.
I shouldn't, we shouldn't think that there are any kind of, kind of delay or, so to say, very straightforwardly, not to blame the system about what the patient has gone through, because right now, unfortunately, when we talk about the ethical, the ethics of justice, so this is, I mean, since we are in a resource poor situation, with our resources very limited to cancer care itself, very few oncologists, very few cancer centers there in the country itself. And the reason why many of our patients do not get their timely diagnosis or timely treatment, and of course, the final decision of final treatment decision being taken, we must perhaps stick to this whole system, that this is the right system, and for this patient, whatever has been done has been correct, has been right. So for, I do not really see any kind of ethical dilemma, or slipping out of ethics and doing anything wrong on that. But had it been the question raised from the family's point of view, then it would have been a little different. Okay.
Only the family had one question: when the patient is so weak and they knew about, the patient is very advanced, why they asked us to put test for him, and why he was, then he had a pneumothorax, and then he was asked radiation. The doctor did not say that. I mean, I also don't consider it as a big dilemma, but when you look at from outside, as a clinician, I don't think they have done anything wrong as the clinician. But when you look at it from outside, as a third party, the relative has had only one problem: being this patient is so weak, and why they have asked us to undergo this biopsy, and then subsequently he had a problem, and then asked to undergo radiation. So that is the thing for the relatives had asked. But as a clinician, yes, we can't say that there is an ethical problem, because this is what we usually do.
Yes.
Well, they could have avoided doing the biopsy and continue for palliative care as a patient who is really weak and the patient had a multiple brain foci.
Yeah. So that will definitely depend from center to center and doctor to doctor. It is very easy for us as palliative care physicians to, tell them that, it shouldn't have been done, and it should have been better to have the patient come to the palliative care part at the same instant. But having said this, the ethics also demands that when you are actually telling a person to give a diagnosis of cancer, for a patient, there has to be a protocol that has to be followed, and that protocol demands a biopsy, right?
Yes.
And
Yes.
at the same time, doing a biopsy for a patient has certain side effects related to it, and one of those is developing a pneumothorax.
Yes.
Right? So so that is a kind of a dilemma. Definitely that's a kind of a dilemma, but that dilemma has had to be with the previous doctor who was treating the patient. Okay. He thought that until and unless I have a proof of this patient, suffering from this cancer, lung cancer, I cannot actually I cannot actually stamp on the fact that this patient is a patient of carcinoma lung, and whatever metastasis has happened is because of the primary in the lungs. So that has to be there. We cannot generally see, these are all dilemmas. We cannot tell these people, the relatives, that the previous doctor was wrong, he has not done that, all what we could have said at that point is that maybe he wanted you to have, he saw some kind of hope that after the biopsy he'll be clarified with a diagnosis and he will be able to give you some kind of radiation, and then you might as well get some amount of, because we do not want him to get deprived of the chance of getting a little bit of cure from that particular disease also, isn't it? So it is, see, if there was a biopsy before and still we are going on to do a biopsy, would have been a wrong thing. But there are no biopsies. The system has made it impossible, a situation where you need a biopsy to be done, and then start your treatment or take your decision while taking that treatment, right?
Yes.
So I think as palliative care physicians, as colleagues also to our oncologists, it is our moral duty to support them in that.
Yes, ma'am.
Okay, so I would, if I am in your place, I would actually support my oncologist or the previous doctor by justifying, not exactly justifying, but then giving these reasons as one of the reasons, so that I do not add up to the guilt that is already built in the family's minds. So that would be my take on that.
Thank you, ma'am.
Excellently said, madam. We should never
exactly the same thing I've told the relatives, but I just wanted to have a discussion on that. How do we manage, or what is the?
No, ma'am, you all are have already gone through these things, and I think practically when we are alone and we fall into such situations, something inside creeps out of our minds and gives us the right way how to handle the whole situation. And God has given all of us this capability to handle these situations, and that's why we do it. I mean, so I think
exactly. The thing is that the palliative care, the importance, significance, everything is not well known. So slowly it has to be, as you said, 15 years. Only thing is that everyone needs to know about it. Need to know about it in the right way. Even now, many myths are only known. The actual meaning or what and where it is done, what for it is done, has to be more, raising more awareness is essential. And we are getting there. So ultimately, I think we will be there, able to develop and help the whole world. Because as such, even though it is so important, and it makes a big part, it has slowly only it's becoming part of curriculum, part of medical teaching everywhere, and so much so in every care. Like as we always say, as madam said in her first slide, palliative care starts at the time of diagnosis. It goes hand in hand. It is a lower in a low level, then it goes along with it and helps. So that is something which has to be understood and taken. So ultimately, we will all get there.
Ma'am, I just want to know, like the hospitals, how do they, I don't think not all hospitals have palliative care in their hospital. So what do they do in case, in the medical college or in RCC, they have a palliative care department?
Madam Sanghamitra, madam, what do you want to answer for that first, please?
Okay. Unfortunately, many hospitals, as of now, do not have palliative care physicians. Okay. RCC, of course, they are mandated to have palliative care departments, and those are being manned by palliative care physicians, counselors. Many have social workers. I have seen, big cancer hospitals, corporate cancer hospitals do not have palliative care departments at all. I won't take big names, but there are huge corporate cancer hospitals which do not have palliative care departments. At the same time, you'll be surprised that there'll be a small cancer unit in a huge hospital, and they will be having a palliative care physician and a proper unit to handle these kind of situations. So I do not see, I do not have any offense against anything, but the point is that we are in a kind of a, transition stage where I consider everybody to be a leader in their own fields. The leadership actually comes on your own. Nobody is going to give it to you. So you have to take that onto yourself, take it as a kind of a start practicing it. And I have in last 15 years realized how the behavior of your colleagues and your friends and everybody in the hospital or in the management setup changes after you bring about such changes. So there are hurdles altogether, but then it is not at all impossible. So, that is what, I mean, Dr. Rajgopal is one person. You can actually take example of this particular simple man who has brought about a huge change in the whole country. Can you imagine? He has single-handedly done that. So we are now hundreds to thousands of palliative physicians all throughout the country. Why can't we do that? So maybe, today you can actually think about bringing about small changes. Even if you do any kind of entrepreneurship on your side, just start doing home visits for patients that you come to know. God has given us everything for the normal life. So if we can dedicate maybe 2 or 3 hours a week for such patients, the differences that we can bring about, it will not take us, long time to spread into the community. So I would actually suggest that to be done.
Yes, madam. As you said, there is enough. Like I have worked in Cancer Institute, Chennai, where we did a big data collection of how much of palliative care facilities available in Tamil Nadu. Even then, by number, there were 42, but physically functioning, it was totally opposite. See, Cancer Institute had a pain and palliative care service, but not everyone, every district or something in Tamil Nadu had. So what, exactly as madam said, big places do have, may not have, and there are some, but still remote places don't even have any facility. But now things are changing.
Yes.
At least big cities are all having. I have like contact for at least 5 to 10 big cities in Tamil Nadu, which will have service. So like that, it is developing. Little drops make mighty ocean. Dr. Rajgopal is a really a ideal person to instigate or give us all the inspiration to do. As madam said, few hours, interest, just raising awareness first. Start with little things, raising awareness, teaching for family and friends, and willing to volunteer and do things, community service, everything will work. And with effort, it will be beneficial. It is slowly budding. So, and it is now increasing in leaps and bounds, and it is being incorporated into many hospitals, curriculum and things. So we will get there. Thank you very much, madam. You said it exactly as it exists.
Thank you, ma'am. Thank you. Thank
It's
you.
not only in cancer, it should be done
Yes,
in
yes.
all end stages.
Absolutely.
Palliation is not only for cancer.
Yes.
Any illness that is not correctable, or that is what, see, lot of pulmonary pathologies,
Yeah.
interstitial lung disease, those type of patients also have life-limiting illness, not necessary cancer. So there are many other things. That's why, so palliation itself doesn't mean it's only for cancer. Non-cancer illness, so many things. So that is what it is. And they, by statistics, they've said it is like some 60 million in the world are suffering from non-correctable debilitating illness. It is not cancer at all. Non-communicable, non-correctable illnesses figures are 60 million in the world. So these are all latest data. All what I'm telling is not old data. It is all recent information. So that is the situation. So it is not only for cancer, it is for so many other issues. So cancer is one, like a tip of an iceberg, cancers.
Ma'am, one doubt.
Thank you.
Like, I have one professor senior. She is working here. Then she, who both kidney, she has failure. So every week she's coming to a hospital twice for hemodialysis. At home she could not do. So that also we can take as a palliative, because she have to take for the whole life. She has to do do the hemodialysis, right?
See,
Can
but
we
again,
take that?
say it is all, no, it is all like resource oriented, how much facility. See, it all depends how, what, that's why it is a fine line. It is availability of resources and availability of whether that hemodialysis facility should be in that palliative care center, no. So you have to think. So these are all, everything being, that's why in palliative care, broadly, you can say hospital-based palliative care, home-based palliative care. There are two things which both exist and both exist in entirety. But everything, you can't put everything into one box. So you have to see that question, what you're asking, that facility will be there only in a tertiary nephro unit where they won't do dialysis here, there and everywhere. So there are, once you go into it, you have to deal with it individually and then see if that is possible in that site.
Madam, just one small comment on
Yes,
that,
madam.
on this particular. So renal palliative care is also being developed in the country. There are strategic groups who are developing it. And if you search the literature, you'll definitely find a lot of, renal palliative care evidence. And I would encourage you to do that. At the very outset, I would advise you to start slow. I mean, this lady is a professor who's undergoing dialysis every 2 or 3 weeks, perhaps. And, dialysis itself has a lot of symptomatic problems. Dialysis pain is one of the most dreadful pain, So you can read about how to take care of dialysis pain, okay? There are many evidences in the literature which will give you appropriate drug dosing regimens to take care of, dialysis pain. This is a very interesting subject, in fact, because people will say, oh, pain medications, not for kidney failure patients, but there are many other pain medications which will help your CRF patients undergoing dialysis get rid of their pain. So I would encourage you to please go through these papers. Yeah.
I think there's nothing more in the chat. Hope everyone has had all their queries, burning queries all solved. And big thank you, madam, once again. And thank you to Dr. Sheena also for your presentation. With that, I think we can conclude with our session today, Sripriya.
Yes, ma'am. Thank you. Thank you, Dr. Sanghamitra, for joining us. and spending so much time for the cohort of doctors, explaining things in very detail. Thank you so much. And thank you, Dr. Sheena, for consenting to give the case presentation as well. So I think that was a very positive note to end a day. And with that note, this is Sri Priya, along with Dr. Sanghamitra Bora and Dr. Radha Venkateshan, signing off from the Tips Eco Hub. See you in the next session with another interesting topic and yet another eminent faculty. Till then, everyone, take care and please don't forget to leave the feedbacks because it is very valuable for us. Thank you, everyone. Take care. Bye-bye.
Thank you.
Thank you.
Thank you, one and all.